keynote speaker and also our chief guest, Dr. James Nyikal. Dr. James Nyikal, CBS, is a trained pediatrician with a fellowship in newborn medicine from Monash Medical Center, Australia. He has served as a lecturer in the University of Nairobi. He was the Director of Medical Services in the Ministry of Health. He has served as a permanent secretary in the Ministry of Health and Sanitation and also in the Ministry of Gender and Social Development. Currently, he's a member of Parliament for Seme constituency, Kisumu County. He has been a member in various committees in the 9th, 10th, 11th, and 12th parliaments. His area of interest include health governance, community and social development, and he's our great defender for our profession. Welcome, Dr. James Nyikal.
Well, Dr. Lesiampe, the CEO of Jaramogi Oginga Odinga Teaching and Referral Hospital, Dr. Kigondu, the president, some time back in this country, he would have gone to jail if he called himself the president. It was illegal. Now the president of Kenya Medical Association, the representative of the Medical Practitioner and Dentist Council and the council members that are here, our guests, the chair of the Medical Association of Tanzania, chair of the Medical Association of Uganda, chair of the Medical Association of Namibia, the chair of the Medical Association of Zambia, and my teacher, Dr. Lwach, my colleagues, classmates that are here, my students that are here, and all distinguished guests, good morning. Good afternoon. Well, I've been here from 8, so I don't actually know where to start, but at least I was number 2 in Dr. Lesiampe's list, but I'm also number 6. I think I will start with number 6. It is really my pleasure, and I want to thank the Kenya Medical Association for giving me the opportunity to deliver this keynote address. Usdin is transforming healthcare delivery. This is appropriate theme for this conference in the circumstances of our health sector today. But as I came in, I also realized this is also appropriate because we are getting, I think this is the first memorial lecture for Professor George Magoha. This is extremely important to me. George Magoha were actually age mates. And when Professor Magoha came back, I was then in the Medical Practitioners Dentist Board. We were doing registration of people who come from outside. I think Dr. Magoha almost came already registered. We had to register his wife. And he told me that if there is any doubt, Dr. Nyikal, I'm going back with my wife. So as you are going to do those things you are doing, just know, did I have any choice? And that is how he always did his things, with great force, and he's always right. So if you have this memorial lecture today and talking about transformation, we are actually on the right track. Healthcare is delivered in the context of social, economic, cultural, and political environment. The actual technical delivery which is subject to these factors, is hugely driven by technology. All these factors are continuously changing. Therefore, healthcare delivery systems must adopt in response to these changes in order to be relevant to the health of the population in the context of the 1948 WHO definition of health, which is health is a state of complete physical, mental, and social well-being, and not a mere absence of disease. If the political environment is not right, even if people are in good physical health, you cannot say that you have a healthy nation, can you? This is the basis of the frequently quoted phrase, transforming healthcare. In fact, healthcare is transformed to be in line with the changes that are taking place. It's critical to determine the changes in the environment to guide the transformative actions being taken. My speech will be general, but really must guide, or should guide, how we see things as doctors. We tend to be drawn to detail of technicalities and leave out the generalities, and that is where we often lose out. That bigger environment, the actions that are being taken in the general environment will determine what we do in theater. Dr. Lesiambi will tell you that the CEO of Wari Farah Hospital will determine whether you have a scalpel blade to do surgery, whether you have oxygen to give the patient. So if you don't take into consideration how he sees the world, then you can't even do surgery. And Professor Gano knows that. So that is where I think, as colleagues, we must look at when you are talking of transformation. What's the bigger picture? The actions we take may be completely new approaches or just implementation of existing laws, policies, plans, and strategy. In this country, when we want to do transformation in the health, we don't really have to look for new strategies and new approaches. Merely doing what is there that we're not doing will take us a long way. So in Kenya, the main areas to be scrutinized, in my view, are look at the socioeconomic status of the people as measured by poverty index, the standard health indices, as well as regional disparities of these indices. We must look at those. For example, the distribution of facilities and services is a critical determinant of access. For example, this, I think, it's obvious to all of us, the regional distribution of level 6 health institutions and cancer treatment centers across the country will determine access to treatment of complicated medical conditions. I don't have to say, you know that. Even in a broader sense, the national and the regional status of the social determinants of health, education, employment, availability of water, agricultural production, industries, transport, infrastructure, information, are actually fundamental to decision making in health. When I was Director of Medical Services, I went to Fangano, the island, some of you know, and Sindo next to it. And we asked people, if you want to improve your health, what do you think we should do? You know what they told us? Build us a road from here to Homa Bay. And they said, why? Because when our women get into labor and we want to take them to Homa Bay, they die on the way before we reach Homa Bay. So this is the context that we look at. Primary health care is another area we have to look at. If we look at the primary health care through the community strategy, when the community strategy was written, I was the Director of Medical Services, and we developed primary health care network. If those are actually implemented, it will be a great game changer. The cost of health care will go down tremendously. We have initiated this program in Kenya, but the coordination between the national and the county government is wanting. The link with higher curative levels is equally weak. If we have community health workers, when we wrote the document it was workers, then it became volunteers, now it is promoters. There's only one thing we are avoiding, paying them. That is why all those names are changing. Workers, they may determine, they may ask to be paid. Promoters, no volunteers, then they are volunteers. Promoters, we can give them something. These are things we really have to look at when we are looking at this thing. That alone made such a big difference in Ethiopia, and that is how Tedros got himself and eventually became the director of World Health Organization, the implementation of the primary health care and the primary care network. Look at the primary care network. If you have a true level 4, which is the former old district hospitals, and your facilities around it, which can do deliveries, and that one at the center can do cesarean sections. Will you need to transfer a woman to the referral hospital in Kisumu for those who come from around here? You don't have to. So we have to look at the area of primary health care and the primary health care network. But the area we really have to look at, governance of the health sector and the health system. The governance of health sector in the context of structures, policies, and legal framework is a key factor for the harmonious and coordinated functioning of the 7 building blocks of the health system. Health financing, human resource, health products and technologies, infrastructure, health information, and even the referral system. Many people think that the referral framework is not considered a health system building block, but in my view, it is the vehicle that moves the patient through the system. When I was a medical student, when I graduated, when a patient was being transferred from Kisumu to Kenyatta, we knew before the patient came. We didn't have mobile phones then. We didn't have internet, but we knew a patient is coming, the days they were seen, where they've been seen, the notes, the drugs they are on, and they'll come in the government ambulance, and we'll be waiting at casualty in Kenyatta National Hospital to receive the patient. In those days, at intern level, we also had a medical officer and the registrars. Do we have that referral system today? Will a patient move through the system like that? Currently, these building blocks are actually our greatest challenges. As a nation, our healthcare financing model is not clear. We have a mixture of tax funding, social health insurance, private insurance, as well as out-of-pocket expenditure. And out-of-pocket expenditure is running and operating side by side with private insurance, both in the private and the public health sector. Dr. Lesiamu, if today one was asked, what is our model of financing our healthcare? Do you have an answer? Is it tax-based? Is it insurance-based? Is it out-of-pocket-based?
Yes, it's a cocktail.
All these things are actually together. Even the taxed one, we have never met them with the target. And when we attempt, corruption is a big negative influence in financing healthcare. My colleagues, this sector can be fixed. And we don't have to discover anything new by merely implementing existing laws and regulations. It also needs to be stabilized, harmonized to realize cost-effective utilization. I've worked with Dr. Lesiamu. If he's going to make a difference, which I know he's going to make here, he's not going to get more money. He's not going to create new laws. He's not going to create new procedures. He's just going to implement what is there. So it can be done. Human resource challenge is fresh in our minds and have directly caused death of many during this ongoing crisis. I didn't pre-plan it just happened, my friend. The frequent strikes are a symptom, not the cause of a broken health system. Despite the evolution, the issue has solutions in the law. People are saying health should have been devolved. But the provision of Intergovernmental Relations Technical Committee in the Constitution, the provision of a Kenya Health Professional Oversight Authority, Kenya Human Resource Advisory Council in the 2017 Health Act. Even if we looked at those who would not be having this strike today, those are available. They are there. Have we developed, have we established KHRAC? No. Is it really working? KHPOA? Intergovernmental Relations Technical Committee? So we have to look at this thing. The frequent industrial action by doctors and other medical workers can be resolved if we abide by the internationally recognized principles of compensable factors for determining a worker's remuneration. There are clear factors you look at when you are remunerating a worker, including the shamba boy. The duration of training and education the worker has gone is a factor. The nature of the work is a factor. The working hours per day, it is a factor. In 1981, what precipitated the strike was when somebody said, you are a civil servant, why should you pay you more? And he said, you work long hours, we do calls. And the person answered, we have employed you as a civil servant. And instead of doing 8 hours, you make schedules that make you work for long, and you want us to pay. And we told him, we are going to make an 8-hour schedule for all doctors. And we did. Nothing could go on. that day there was a strike. Just not recognizing that somebody works long hours. The risk factors the employee face. When COVID came, people who died because of the nature of the work and their exposure, the largest number were Mungusu died. When I shed tears in public, many people asked, why are you crying? Then I knew this country, nobody feels about anything. If they were asked, why are you crying? And the doctor has died without getting ICU care, having not been paid for 5 months. Dr. Lodge will tell you that a lot more health workers have TB than other people. That's a risk. That's a compensable factor. You should be compensated for that. The expenses that a worker undergoes to carry out the duty that they're given. If you are called at night and you drive your car, on whose purpose are you driving that car? Is it not the purpose of the employer? Why should you not be paid a commute allowance? If you look at the interns guidelines, that if the intern is on call, he must go home. He should be released at latest by midday. That is what is written. But he started work 5 o'clock the other day. He's being released at midday, and he'll come to work at 5. During the negotiation in 2002, we said, okay, don't pay us that allowance, but then we want overtime. Dr. Lesiem asked them to calculate the overtime that they pay. Me, the negotiation, I'll agree. We remove those, but we get overtime. They'll pay a lot more. The unique circumstances under which you work must be paid. There are people who are surgeons who will stay in theater even until midday. When the wrong surgery was done on somebody's head in Kenyatta, how long did those people stay in theater? Did they go away because time was up? It is these compensable factors that are the basis of the allowances which are now being withdrawn. I'll say yes. I worked on those allowances, and that is what pushed the salary to 2006. We can remove them, but then we must compensate each and every rate. So we need serious negotiations with the pen and the paper and looking at every factor. The decision to pay intern salaries or stipends must be based on the analysis of the work they do. For example, the case of medical interns, they are part and parcel of a workforce in the health facilities of level 4 and above. For my colleagues in this country, we grade hospitals in levels. Level 4 is where you actually have a hospital where you will have at least the 4 basic consultants. You will have a theater, you will have an anesthetist, you will have a blood transfusion, you will have a lab, a place where an intern can work. Those levels of hospitals and above. A normal working structure in those hospitals is there's a first on, second on, third on. Who is the first on call? So he's not an employee. The intern spends more hours in the hospital than the medical officers and the consultants. For these interns, once the conditions of internship, including remuneration, is set, they do not have to work in government hospitals only. In 2000, we used to have internship being done only in the 8 provincial hospitals. We opened them up. So long as you meet those level 4 conditions. We opened them up to mission hospitals. If, and on this table I expected more of us, but the council is here, and my friend Dr. Lesiampe, you are the closest to, you know walls of ears. You may be the only ear in this that can hear what I'm saying. So let me hear it. If you only say all hospitals, private or public, if they're level 4 and above, they must have established positions of interns and fixed number, whether public or private. In the same way you put conditions for the registration of our hospital, the number of nurses and so on, we can also say for interns we do the same. Something tells me we will create so many positions of interns that the 1,900 we are talking about may actually be swallowed.
Yes.
But if we do that, because they are going to be the first on call, working 18 hours, the person they're working for must pay. And so, the county government will then have to pay. But we have made it a training, and so they are students, so we want the national government only to pay. I know private institutions that are asking if they can also be given interns. Let's open up.
It's open actually.
Before we stick to say 70 and they ask, where did the 70 come from? Nobody has ever told anybody. Where did the 70 come from? I think this is something we can do. We need to open up. I think this is a discussion I'm putting. I have no other forum. You think of a forum in Parliament. If somebody thinks I'm going to say something, I'll not get a chance to speak. My friend from Nanyuki was asking me. You know how many times I put my card to speak about this trial? It will not be, because the people know what we're going to. Some of us are unfortunately so predicted. So we're easy to manage. The other controversy is payment for registrars in postgraduate program at level 6 health facilities. Registrars, these are people in postgraduate training. They are a workforce for the hospital. They are a workforce for the hospital. All people who have run level 6 hospitals, you have run one. Without them, the hospital will not work. And then somebody says, they are students. They do all the surgeries. But then, we are stuck from the point of devolution. We have not moved, because now they were being paid by the national government and they were working in these hospitals. Now, when they are coming from the counties, we want the county to pay them while they are working at the referral hospital. Why should Kenyatta pay for registrars? Why should Kenyatta get registrars paid for by Kisumu? And the registrars are working for Kenyatta. What is my proposal? I'll put it even in Parliament. We establish training positions in the referral hospitals up to the number of the registrars we need. And we pay from the national government. We pay to Kenyatta because Kenyatta needs staff. Moi needs staff. And those are the staff it needs. Then we pay. The money comes from the same kitty. Whether it goes through the county or it goes direct. So then when they release to go for postgraduate, they then take these positions. And since these are transient positions 4 years, when they leave it is actually a revolving position. I know you and I know you. Somebody may hear you. So that the counties can then have the money that they had when they provide the registrars to employ other doctors, even if it's on contract. don't know where this gene of contracts is coming from, but it is coming. We will deal with it also. So then, that again, we have proposed many times, so that you get paid by the person you are working for, whichever way the money is moving. Clearly, all these human resource issues can be resolved through provisions existing in our Constitution, Acts of Parliament, regulations and policies. If you ask me, I can tell you each one of them. As the country struggles with human resource management, the training programs are not aligned to the country's needs, both in numbers and in cadres. We said we are going to train cadres. We are training all cadres since we started. Whether things are changing, we are training the same cadres. The numbers are going. Do we train the numbers that the country needs? Do we plan their absorption? Are the standard of staffing in our both public and private health institutions linked to the intake in our colleges and universities? First of all, universities were your needs. If we linked that, it would help. Do we control the quality of training in colleges and universities? Currently, this is weak, but it's likely to get worse with the new provisions in the Universities Act, creating Kenya Universities and Colleges Central Placement System. No university and college now is going to pick their students. There's a central placement system. And also, the Commission for University Education also been created, and it does not have to refer to our regulatory authorities during curriculum development and implementation. The Medical Council cannot say what the universities are teaching and the number they are teaching. And the students are so many that some are texting while you are. If you are going to do a demonstration and you have 100 students in your ward round or 50 students in your ward round, and you want to do a rectal examination and demonstrate the fungation that this is fungating mass. We have to relate the number of students we take with the number of beds we have. Are we doing that? No. So we have systemic issues. We are trying to get this Commission for University Education Law looked at, because that is affecting all other professional bodies, including engineers. The lawyers were smart. They said, train them the way you want, we don't care. But they will never practice law in this country until we train them again. I think that is wrong, in my own view. Yeah. Children can't go get a degree and then they can never go and practice what does the LLB from Nairobi mean if you have not got a diploma from the Kenya School of Law? Nothing. So the diploma from the School of Law is actually what is now matters. We don't want medicine to go that way, that doctors come with MD-CHP, but they never treated patients, because we have to put another example, because Commission on University Education stopped us from getting involved during the training period. As regards health products and technologies, this is another building block. Devolution has offered an opportunity for what I was really hoping for as a Director of Medical Services, for a revolving fund arrangement. Counties pay KEMSA, KEMSA buys the drugs and distributes. What is happening? All the debts of KEMSA, 90% are the government. Because even if it's the counties, where do the counties get money? We should still go to Treasury and ask Treasury to give counties money to pay KEMSA. In my view, this is not a financial issue, this is a management issue. In all areas of the health sector, the Constitution provides, through the Intergovernmental Relations Technical Committee, the coordination link between the national and the county government. The Health Forum in this committee is a structure for technical officers from the national and county government to share policies, standards, plan implementation, monitoring, and regulation together. It was realized when the Constitution was being promulgated that there will have to be a link between the national and county government. We created this. It's not working. What is the problem? There's another structure called the Secretariat of the Council of Governors, which was created before the Intergovernmental Relations was established. Now the two things have not worked together. So this forum is not working even if they meet. If you ask the officers, they tell you when we meet there, for what we have said, we don't. If technical people saying what they're meeting and discussing does not meet, then what are the politicians discussing at whatever other level? The only thing is to actually get the Secretariat of the Council of Governors and the Intergovernmental Relations Committee to meet. I know one is not legal, but if they work, this desire to have health taken back to the national government will not actually be very big, because we have structures in law that can help this. Now we also must look at technology. Advances in technology provide opportunities to transform health systems. In this regard, digitization and purchase of modern equipment are the first step in improving efficiency and expanding the functional and the regional scope of our services. We had two presentations here of new things that are coming. Dr. Lesiampe said that with all those, however, well-trained and diligent workers are necessary to realize the advantages of technology. We can share pictures digitally. I've been a case where I was in Kisumu and the next day it was sent to Nairobi to be read. That is how easy it is. I was one in Nairobi where it was sent to the consultant in his house. In both cases, the patient waited for more than 6 hours. So how did the technology help us? In one case, when we went the following day, the system had broken down, so the consultant couldn't see the patient because they could not access. So who was needed? An IT person, so that the digital information is available to the consultant. The consultant was waiting, and the patients were waiting, and they were being booked to come next month. Who was now in charge? The IT officer. So when technology comes, our diligence and commitment to work as human beings must still be looked at. Professionalism, integrity, and empathy cannot be transmitted digitally. So my colleagues, even when technology comes, Dr. Lesiampe was right. 20 years, I'll be saying about written. So this feeling, I may be lucky to have my name in that board. But at that time, those of you who are there insist that with technology, the human input must be respected, and those people must be there and work in an environment that they cherish. I'm a doctor, I know when you're in a bad mood, it affects the patients. So if you are now forced, if these striking doctors are forced back to work, it will reflect on the nature of work, the commitment. You are called, you can't wake up. You know, when you're in a bad mood and you are called because you have to go to theater, you take longer than if you're in a good mood. And if it is a fetal distress, the baby will die. So these are things that we really must look at. Technology, we must link technology with human resource. The other way we have to look at is doctors as leaders in the profession. This is what is ignored. I think the court decided that that anybody can be Director General, isn't it? I don't know where that one is going. But even if the laws that are man-made are not giving us doctors, my colleagues, the leadership, God gave us the leadership as a profession in regard to human life. We cannot abandon that, however bad politics are. It may derail you the way it has derailed me from medicine, but you'll make some contribution. The role of doctors as leaders in the profession cannot be gainsaid. Systems can be built, finances can be raised, health supplies can be availed, equipment and facilities can be installed, but professional integrity and commitment to preserving and improving life is the glue that puts all these systems together. We, as doctors, are the duty bearers in this. Our ethics, integrity, and commitment must be the vanguard against unprofessional commercialism in healthcare delivery. That is the only way we can protect the dignity of the profession. I know we can deliver. Health is hard to run as a business and make money. But it will be run as a business. It's being run. But you know that the US, where it is really commercial, their health indices are worse than in Cuba. You know that? So the people will make the money. But I think as we fight, let us also maintain the leadership we have. From internship, while we are signing the Hippocratic Oath, through general practice, to the highest level of specialization, ethical practice, professionalism, and commitments to patients' care and welfare must be our mantra. Sometimes, in order to fight for the patient, you must fight for yourself. You can't help the patient if you are dead. The truth is, you can't starve a house girl and expect your child to do well. You can't beat up your babysitter. You beat them up, the house girl, and you kick them. Then you go away and leave them with the baby. And now you are thinking that you have power. You don't have power over that house girl. So long as you live here, you have left your baby with them. So it should be understood that sometimes when we want to improve our well-being, it is good for the patients. But I think we must also, in our ethics and the way we conduct ourselves, let that be shown. The public will be with us, but if you miss that, the public will abandon us. And in this game of politics, the moment it says that the public has abandoned you, you are on the slaughter table, mercilessly. We must be guided by our duty to our people at individual patient level, even at the community, the running of health services. In summary, to transform healthcare, we need to take the following steps. Address social determinants of health. We were being told about Turkana. Had Professor Menya not shown us that there is malaria in Turkana, shall we be giving them nets? No. And they die. Yeah. So the social determinants, it is not the visitors, it is the migration and the irrigation channels, isn't it? That's what you told us. So the social determinants, availability of food. So when we get bad fertilizer, don't think it doesn't affect us. The malnutrition that follows months later will be your problem. We must build and implement primary health care because it will reduce the cost of care. Actually, if we build primary health care, it will reduce the cost of care. And public health professionals and ministers of health, particularly counties, have this is their mandate. Establish and implement the working health system by focusing on the building blocks. We mentioned them. Professionals in public health, in ministries, I thought we'd find some here. National government and private facilities must play a bigger role in this. building a committed, progressive, professional and ethical body of human resource for health, training institutions, ministry of health, professional bodies, regulatory bodies have a say in this. So let us put all ourselves in this. As you listen to me, some may be asking, what has this speech got to do with transforming healthcare? The answer is simple. You cannot transform a broken system. You have to fix it first to establish a stable foundation for transformation. And that is what we must do in our country. When we fight with politicians, let's not see just ourselves and the politicians. Let's see our people in it. When you become a politician, you will know what it means if health services are running well. I wake up in the morning, even today I got a report of a patient I'd sent to Moi. Patients come to you. So if we take good care of them, it will be okay. So as a country, we must fix the broken system. I view the strike as part of fixing the broken system because addressing and for this profession, when the intern dies, we are all
dead.
We must die with the
Intern.
On the intern we start. And where we have reached, my colleagues, we cannot leave this thing to the doctor in the public sector only.
Correct.
I'm asking my colleagues in the private sector, what contribution are you making? Can it reach a point that we are saying, even us now, if you are doing that to our colleagues interns, we are also stopping? Can we? Because there must be selflessness in this. Let's join the negotiations in many ways. You have MPs, all of you have MPs. We are only 345. Doctors are many. In your constituency, go to the MPs, let them understand what is happening, what an intern is. If need be, even in the private sector, let us put down our tools. Because the people, when negotiating in the evening, go to their doctors. And I'm sure they are smiling and asking, what are they doing? They are asking you, how are you going with them? That them is you. When one doctor is dying, you are dying, whether you are in private sector or in public service. You cannot say that there is a distinction. So how are they doing? Those are also our colleagues.
We are going to do a very nice appreciation to our guests. And as we do that, I want to welcome Dr. Linda, Dr. Liz, and Dr. Kigondo for a small appreciation to our keynote speaker and chief guest, to our host, Dr. Lesiampe, and Professor Ogendo. Kindly, as we are doing that, I want us to do the 4, 3, 2, 1 clap. And I want the last one to